Nasogastric tubes. Nasogastric tubes could be inserted at the bedside, preoperatively after the client is sedated, or during surgery. It's used for decompression, removal of secretions and gaseous substances from the GI tract to prevent or relieve abdominal distension with gastric or bowel surgery. Can be used to lavage the gut, where you irrigate the stomach in cases of active bleeding, poisoning, or can be used for gastric dilatation for diagnostic tests. You can use it to provide an analysis of gastric contents. To determine the gastric pH can help identify a variety of illnesses or stomach and digestive problems. You can use them to administer medications or nutritional feedings. Installation of liquid nutritional supplements or feedings into the stomach for those clients that cannot swallow. Can be also placed in the duodenum or the paroxysmal jejunum for feedings. They're used to treat obstructions. They're used for compression. You can use internal application of pressure by inflating balloons to prevent internal hemorrhage, or simple aspiration of gastric contents. There's two main types of tubes. You have the Levin and the gastric sump or Salem sump. The Salem sump often has the vent or a pigtail that helps equalize pressure, and these are the tubes that are preferred for decompression. Nasogastric tubes that are used for decompression are your Levin, your Salem sump, your Moss, or your Singston Blakemore. Singston Blakemore is also used for the treatment of esophageal varices. There's also nasoenteric decompression tubes that are used for decompressing the stomach to allow healing. Due to the intestinal placement of those tubes, radiology might be required to help make sure that it's in the appropriate place, and stylets may be used to place those. And then you have nasoenteric feeding tubes such as a Dobhoff or an Enteraflow. This is a picture of the Singston Blakemore tube. You notice the balloons on the tube. Again, these are really good for esophageal varices or to help control other bleeding. Passing a Cantor tube, it has a mercury or water weighted bag in it, and it's used to help with gravity to get it to where it needs to go. This is a picture of the nasoenteric tube feeding. So how do you insert an NG tube? It should not be delegated to assistive personnel. They can help with measurement and recording of drainage and providing oral and nasal hygiene measures, but they cannot drop one. Make sure you check the medical order, what type of NG tube is to be placed, and whether the tube is to be attached to suction or a drainage bag. Excuse me. Explain the procedure to the client. If the nasogastric tube is rubber, you need to place it in a basin of ice for 5 to 10 minutes. If it's plastic, put it in a basin of warm water. This will help improve flexibility. Make sure you provide for privacy and gather all of the tubes, all of the equipment that you will need. The traditional method of measurement is measuring from the nose to the ear to the tip of the xiphoid process. The tube should extend from the nares down to the stomach, and the distance is going to vary with each client. Once you measure, then you take a small piece of tape and you place that around the tube. You will then wrap about 10 to 15 centimeters or 3 to 4 inches of the tube around your index finger, excuse me, and then release it. It will help decrease the stiffness of the tube. Make sure you assess your client prior to the procedure. Excuse me. Bowel sounds, listen to all 4 quadrants. Check your oral and nasal cavities. Figure out which nary is going to be most patent. You can do that by instructing the client to breathe through their nose while holding one side closed. Check the history for nasal fracture. Make sure that you select the side of the nose that has the best airflow. Wash your hands, put your gloves on. Client should be in the high Fowler's position. Raise the bed to a comfortable height for you to work. Protective towel. Lubricate the tip. To start the insertion, you will have the client tip their head forward, and you will insert the tube slowly through the nair. When you feel some resistance, it will probably be the back of the nasopharynx. You will need to apply just a gentle downward pressure, maybe rotate the tube a little bit. You don't want to force it because it will traumatize the tissue. But if the resistance continues, then withdraw the tube, allow the client to rest, try the other side. If you're unable to insert the tube in either side, then stop the procedure and notify the physician. Continue the insertion until it's just past the nasopharynx, and give the client a chance to rest just briefly. They can have a few sips of water unless it's contraindicated. The next step is going to require the client to do some swallowing. So you hand them the water with the straw and instruct them to swallow, 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 as with each swallow you're pushing the tube down until you get it to your mark. If the client is not allowed any fluids, then they will have to dry swallow. If the client begins to cough, gag, or choke, withdraw the tube a little bit, instruct them to take some deep breaths, and take some sips of water. Sometimes that tubing will accidentally enter the larynx and it will initiate the cough reflex. If it initiates a cough reflex, then chances are it's in the wrong place. Gagging is normal. But if they begin to vomit, you're increasing the risk for them to aspirate the vomitus. So if coughing continues, you need to pull the tube back and again instruct them to tip their head forward. If they tip their head back, you're more likely to go into the trachea versus into the esophagus. So tip the head forward. If gagging continues, make sure that the tube is not coming out the mouth, because sometimes it will coil up and coil up into the back of the throat. When the client relaxes, then you're going to advance the tube to your mark. Anchor the tube with a piece of tape that you have prepared in advance that is split. The split side will wrap around the tube and the non-split side will be taped to the patient's nose. You then need to verify placement by checking your policy to make sure that you're using their recommended placement techniques. You can use several different types. You can inject 10 to 20 mLs of air into the tube and auscultate over the epigastric area. It's not the most accurate, but it is the most widely used. You can get radiology to take an x-ray. Ask the client to talk. If the client is unable to talk, then the tube is passed through the vocal cords. Make sure you inspect the back of the throat for the presence of a coiled tube. Aspirate gently on the place a syringe on the end of the tube and aspirate back to obtain gastric contents. Gastric contents are usually cloudy and green, but they're frequently whitish or tan, bloody or brown in color. If they drank a lot of water when you're placing it down, you'll probably just pull back some water. If the tube is in the duodenum, it will be yellow or bile stained. If it's in the esophagus, it looks like saliva. Aspiration of contents means or provides a means to measure fluid pH, and that can help further identify tube placement. Gastric pH will be acidic. It will be a 4 or less. Intestinal pH is greater than a 4, and respiratory secretions are usually 5.5 or greater. If the tube is not in the stomach, then you need to advance it just a little bit more and then recheck placement. So securing an NG tube after it's properly inserted and you've checked placement, you can clamp the end or connect to suction. Secure the tube with tape to the client's nose, or you can use a fixation device. Fasten the end of the NG tube to the client's gown to help prevent dislodgement or pressure on the nair if the tube moves around, or you can tape it to the forehead. The head of the bed should be elevated 30 degrees with an NG in place to help prevent esophageal reflux. Make sure you teach the client about tube irritation. It will get a little bit better, but sore throats are common. They may be allowed to suck on hard candy or throat lozenges, or maybe even a throat spray, depending on physician preference. Record the length, size, and type of tube inserted and which nostril it went through. The client's response, any symptoms that could indicate malposition, the client's status after the tube has been placed in position, and whether it's clamped or connected to suction. Record any pH readings that might have been obtained, the color of secretions that are obtained in the tube, the difference between the amount of saline that was instilled or gastric aspirate. This will go on your I&O. So if you inject any fluids into the NG tube, that needs to be recorded as input. Record on the nurse's notes or flow sheet the amount or character of contents that come from that tube every shift. And how did you confirm it? Confirm placement. When you monitor, you always check the suction type, whether it's continuous, low, medium, or high. If it's intermittent, look at the drainage, the color, amount, consistency, and odor, your CACO. If you suspect blood, you can hematest. Make sure that placement is reaffirmed. Check for distension of the gut and for bowel sounds. Remember, clamp the tube when you're checking for bowel sounds. Assess the nostrils. Clean them as necessary. Provide oral care, assessing the mouth. Make sure the tube is secured appropriately and record your I&Os appropriately. When you discontinue a tube, make sure you check your orders before you do that. Explain to the client that removal is a lot better than inserting. Assess the presence or absence of abdominal distension and bowel sounds. If there is distension or no bowel sounds, make sure you let the doctor know before the tube comes out. He may change his mind. You can do intermittent clamping and unclamping for 24 hours prior to removal to determine any residual. It kind of makes sure that the gut is working. before you pull the tube out. Check for nausea, vomiting, or distension again. Turn the suction off. If you continue to suction during removal, it can actually traumatize the tissues. Make sure you wear gloves. Drape the patient with a towel or a disposable pad and give them an emesis basin in case they might need it. Excuse me. I hand the client several Kleenexes, and I have several in my hand. Tell the client to take a deep breath, blow it out, and you pull the tube out steadily and smoothly with your hand holding the Kleenex close to the patient's nose. Wrap that tube in a towel or the disposable pad. Clients usually don't want to see it. It's usually nasty. It has a lot of secretions and goobers all over it. Make sure you measure output and assess the content. Clean up the patient, their nose, their mouth, whatever procedure they have for drinking if it's not contraindicated. Reposition them and dispose appropriately of everything and record the procedure. To irrigate a tube, you always want to make sure it's in the proper place. Elevate the head of the bed into semi-Fowlers and make sure that suction is clamped because you don't want to suction out what you just put in. Irrigate it with 30 mL of normal saline. Do not irrigate into the air vent. Hold the syringe with the tip pointed to the floor. If you're unable to irrigate or resistance is met, reposition the client and try again. If repeated attempts fail, then you need to notify the physician. After installation of the irrigant, you will immediately aspirate and measure the volume. If there's no return, inject 20 cc's of air and try to aspirate again. Air sometimes will help reposition the end of the tube. Repeat irrigation as necessary or ordered. Make sure you reconnect to suction and record on I&O. Excuse me. Oral care should be regular and frequent. Make sure you're assessing tissues for any irritation or breakdown. It helps promote client comfort. Oral hygiene should be done with moist cotton tip swabs, or you can use the lemon swabs. You can also use the sponges. With cotton tip swabs, clean the nose using water-soluble lubricant as necessary. Change tape if need be. Again, checking nose tissues. If there's a lot of dry mucosa, sometimes putting some steam, vapor, or some type of vapor inhalation to help. When administering medications, again, you want to make sure that your medications can be crushed or dissolved. Make sure that you don't crush the wrong ones. Medications that have a pH less than 4 can go down an NG tube. Any crushed medications need to be dissolved in some warm water. Make sure it's room temperature. Check placement of the tube prior to administration. Flush the tube with water prior to and after administration of medications. At least 50 to 150 mLs. Suction has to be off or you're going to suck those meds right back out. Usually you will leave the suction off for approximately 30 minutes following administration. Make sure that you add any amounts to your eyes and nose. Tube feedings. You can do intermittent boluses with large amounts of 300 to 400 cc's every 4 to 6 hours at designated intervals. You can do intermittent gravity, which is usually over about 30 minutes at designated intervals, or you can do a continuous infusion that will usually require a machine, and that's preferred to reduce aspiration. distension, nausea, vomiting. Diarrhea is extremely common with tube feedings. Usually your continuous infusion will go at 100 to 150 cc's an hour. So, responsibilities with tube feedings. Frequently you'll check for residual gastric content, which means that prior to every intermittent feeding and about every 4 to 8 hours during continuous feedings, you're going to stop the feeding, you're going to aspirate to see how much you are able to aspirate. If it's over 100 mLs, then that means that digestion is not moving along the way it should. Reassess it in an hour. If you get over 100 mLs a second time, then you're going to notify the physician. Maintain tube function by flushing it periodically with 15 to 30 cc's of water, for example, before and after every dose of medication and feeding, after checking for residual and or pH, every 4 to 6 hours if you have continuous feedings, or if feedings are discontinued for any reasons. With medications, crush the medications, then dissolve them in water. Do not mix liquid medications with other medications, and don't mix with feeding formulas. If you have a small bore tube, then you're going to need at least a 30 cc syringe so the pressure does not rupture the tube. Gastrostomy feeding by gravity. You have a bag and tubing changed per facility. Policy, it's usually 24 to 48 hours. You only hang what is going to be consumed in 4 hours to decrease bacterial growth. Additional considerations, you always want to minimize aspiration risk by checking tube placement prior to every feeding or medication administration and at least every shift. The client should be in a semi-Fowler's of at least 30 degrees for 1 hour after a feeding, and at all times if they're a continuous feeding. Make sure they're well hydrated. Water should be given every 4 to 6 hours and after feedings to help prevent hypertonic dehydration. They need at least 2 liters a day. Observe for signs and symptoms of dehydration and make sure you watch the INO for fluid balances. Maintain normal bowel elimination. When they are on tube feedings or of any kind, expect pasty, unformed stools because there's low residue in formulas. Diarrhea is a frequent problem with tube feedings, which is basically defined as a watery stool, 3 or more of those in 24 hours. And always assess and protect the insertion site.